But we're still alive, they told me. So, anyone has a question?
My question, it was really interesting, really insightful, and something that you said about the networks can be interesting. Because at the end, seems that addiction is not the only one, and not the only mental disease that is changing these networks. It seems also that in depression there is expansion of the silence network, but I'm not sure if in addiction at least we can say that the issue is in the silence network or is in these three networks, or what is happening there?
That's a very good question. And the question, I just reformulate the question. The question is, when you see a patient with addiction, it's almost never only addiction. There are always something else around addiction. And when you do the clinical work, you see that is the reality. I mean, people have depression as well, they have anxiety as well, they have other challenges, and you need to take that into account of what you are already doing. Most of the trials that people have done in the field of using TMS for depression, from the first day when they have been designing their trial, they excluded people with substance use. They have been thinking, okay, I mean, people with substance use, they might not be responding really well, so let's just exclude them and just do kind of depression trials on those who have only depression. And now we want to use all those good things about TMS in depression, but nobody knows how TMS is going to work in depression for those who already have addiction as well, because nobody has done that, because we have just excluded that large part of the population. Okay? This is also true for addiction as well. There are some studies in the field of addiction that they just hand-picked people from the field of addiction that did not have anything else. And that is not the reality. Okay? So we need to take into account those things in terms of how people are experiencing different psychopathologies and how these different psychopathologies are contributing to experience that we have. And the good thing about individualized modeling is that gives us an opportunity to be able to take all those factors into account and seeing each individual person as each individual kind of entity and optimize and do some like a patient-centered intervention based on all the things that they have. And that is going to be hopefully the future that you, I mean, as the next generation are going to contribute to that sort of activity, hopefully. Any other question?
Also, another thing that keeps me wondering, when you were talking about the NNS and the effect size that is low to moderate, in large samples, we always found a really small effect size. So I don't know how to reinterpret the effect size in terms of individualized and the small samples that we always get and the large samples, how we can I don't know.
That's another really good question. The question is, with the larger database like ABCD database or UK Biobank, when you have a large database, then you can find even very small effect sizes. Very small effect sizes could be significant in statistical analysis. But in reality, those very small effect sizes, you can publish them somewhere, okay? But they are not meaningful in the actual clinical practice, because something like 2% of the variance or 5% of variance are not very much important. I mean, if you have pain and you receive something that reduces 5% of your pain, it doesn't change things very much, right? So you need to at least have something like a 30% change in your pain to be able to have something meaningful and say, okay, it made something for me, right? That is the reason that, I mean, there are people who, I mean, I think that the large studies are very helpful in terms of providing databases for these foundation models. But eventually, we need to go for individualized interventions in a way that they have larger effect size. Now, there are studies that they have done individualization and they showed that you can see the effect even in 5 participants. Even you have 10 participants, you can see that large effect size. And that is the hope that they have in terms of individualization would take us to a level to be able to find large effect sizes compared to larger studies that they have very small effect sizes.
I think probably the answer is pretty simple, but you talked about increasing synchrony, and sometimes we think increased synchrony sounds bad. because that's what you have in epilepsy and other certain conditions. So what you put some sort of limit on that increased synchrony that is in a closed loop situation.
That is very good question. Another very, very good question. When we do some closed loop, are we targeting just maximizing the connectivity and synchrony between nodes? Or we want to get to an optimum point, and after that optimum point, the function of the network goes down. Right now, what people are doing, because we feel that we are so down on the entire distribution, that what we are doing is just getting that a little bit higher. We are still very kind of far from the peak and going down. But that is a very important question. If we want to extend that in the future, we need to have a sense about that sort of distribution of network connectivity and network function. And this is something that as you can see, that linear models cannot detect. So we need to have other types of models to give us a sense in terms of, okay, that is the optimum point, and beyond that is not going to work. And even if there are pieces that are on the other side of the network, we just want to get them to the other part of the synchrony. And that is something that we do not have that data right now in the field of addiction, but that's a very important thing to explore and consider. I totally agree. Yeah.
No more questions. Yeah.
Thank you for the nice talk. It made me think about numbers, biomarkers. So I think that what you say about biomarkers is not only for addiction, can be for other kind of disease. So it's very nice to think about all these. And I'm thinking also that you made a point in the regions that you stimulate, but I'm thinking also about the parameters of the stimulation. What do you think about that?
Honestly, I think sometimes parameters of a stimulation are more important than the area that you are stimulating or the optimization of area of stimulation. Because most of the TMS that we are doing is still stimulating pretty large area in the brain. So it is not really pinpoint area. It's something like a 1 centimeter to 1 centimeter. So it's not very focused. And I realized over time, it's important for us to optimize the spatial location of what we are doing for a stimulation. But I think dose of a stimulation is way more important because you need to get to that area. So dose optimization is always way more important. And now people are saying it is important that when you are actually doing the stimulation, because brain is an oscillating organ, right? That part of the brain is oscillating. So if you shoot the TMS pulses on the top of that oscillation compared to the time that you shoot that stimulation on the down part or trough part of that oscillation, is it going to make a difference? And it seems that yes, it is. And that is the reason that we do what we call EEG-informed TMS. And even there are a group of people in our university that are doing closed loop EEG TMS. They record EEG, and based on the EEG, they just try to put their pulses in an area that they are interested in terms of, and they realize, for example, if you do then the peak compared to trough, the response will be different. And trying to optimize. So there are different levels of optimization. The level that I discussed today was mainly about the spatial, the area, location. But temporal is also important. Dose is also important. And the third factor that is very important is the state or the context of the stimulation. What does it mean? If you have a patient in the clinic doing TMS for depression and they are receiving TMS for depression, if they sleep, the TMS is non-effective for depression. They need to be awake. Why? Because when you do the TMS, you tap into a network that is connecting your DLPFE to subgenual cingulate cortex. When you go to sleep, that network is not connected anymore. So you do not have access to that area that you have been trying to have access. Even in the field of addiction, some of the interventions that we have, we need to make people having craving, and now they are in a state that there are specific connections in their brain that then you can tap into those connections. So even the state of the patient while you are doing the stimulation is going to be important. So we have at least 4 major dimensions: spatial optimization, temporal optimization with EEG I mentioned, dose optimization, and context optimization. So you need to do optimization at least in 4 different dimensions if you want to do the right thing. Absolutely.
Biomarker is a gold medal in research. How do you know the difference between an intrinsic biomarker from the produced by substance use disorder? How do you know?
I'm not sure if I can completely understand the difference between intrinsic and something that is being produced by substance use disorder. We know that those measurements that we are discussing about, first of all, I mean, they are dynamic, okay? For example, we say that the connection between frontopolar cortex or inferior limbic cortex to nucleus accumbens is important, right? This is what Mark was mentioning. And even if you do a stimulation there, you can have changes in input to nucleus accumbens, right? We have just submitted a paper showing that those who are methamphetamine users, that network, that connection, over the time goes down. So that network is way more connected when you are in your first years of using methamphetamine. But over the time, then the connectivity on that network changes. And the other network that we have been discussing about DLPFC, the connection of DLPFC to subcortical areas increases over time. So there are some of these networks that they go down, and there are some networks that go, I mean, this is a dynamic change. So it is not saying, okay, you are a substance user, you are like this. It is not the case. I mean, based on your trajectory in substance use, things are changing. And also, people do not start from the same point. You might start using substances when your network is in this area, and then increase that connectivity over time or decrease that connectivity. But the second person could start it from here or from here. So based on their neurodevelopmental trajectory or their life experience or their adverse things that they had in their life, they can even start from, as you said, they can have different intrinsic biomarkers in terms of they have some neurodiversity in terms of how they are different from others. And even they have different starting points to start with, and then being affected by substances. So there are lots of variation. And that is the beauty of life. First, all of us are different, right? And that is the beauty. But meanwhile, how we can consider that neurodiversity and bring in the neuroplasticity techniques that Mark was mentioning and modulating those things in a way that we can reduce the suffering from substances. So this is the hope that we have. And the promise of individualized intervention is just meeting the person in wherever they are. And while we have a foundation model that is being trained with 80,000 people, we still see that specific person as each individual one that you need to take into account all the individual differences that a specific patient has and consider that in their treatment. So that is the hope that we have for precision medicine. One more thing that those who are interested, because I was discussing that with Eduardo, we recorded a TMS workshop for 2 days, and I sent a link to Eduardo. The workshop is free of charge. So the link has a coupon that would just give you free of charge. It's on Udemy. So if those who are interested to have that workshop, the free access is with Eduardo. So you need to give $5 to Eduardo and receive that. But yeah.